Hello. How you
Hey,
doing?
how you doing?
Doing all right. How you doing?
Good, good. I know this is like office hours, right? Kind of like,
Yeah. So kind of like yesterday, but maybe a little more specific to group, or just it doesn't
okay,
have to be around a specific topic. I know the NLP stuff, they usually try and pick a subject just to get people interested. So if people have a particular interest that people want to go through, then it's there, but it's not necessarily this is like very free for all. So you can kind of anything goes. So yeah.
I have a little bit of a strange question, but I don't know if Jessica wants to go first.
I don't know. I mean, depending on your question, we may end with a strange answer. So, uh, Jessica, welcome. I don't know if you and I have met yet. My name's Andrew. I'm one of the consultants with Practice of the Practice.
Hi.
Hi,
Yeah. Nice to meet you.
nice to meet you too.
Yeah, Steve, go ahead. I'm just here to listen.
Oh, okay. I'm
You'll
just,
probably have questions because I like to have discussions. So I'll probably check in and see. So
Good.
welcome. Yeah.
I guess, the two questions they seem like polar opposite. The first is if you were in my position again, like let's say a solo practitioner, and you were thinking about group, is there anything you would have done differently, like right out the gate?
that's a that's a big question.
I know.
Um, it's a difficult one too because there's different phases of group practice, and so um, when you're when you're in solo practice. So I started solo, and I was actually a next level practice community member. Um, Gosh, going back to 2021, it seems like anyway a long time now. So um, was an NLP member of my small group, people were like, your business, because you have a PLC, it works like a vehicle. And there's people that want to own a vehicle and drive it and own and operate and maintain it. And there's people that don't.
Right.
And for the people that don't, you could offer them a ride in your vehicle, right? Or offer them a place to live in your house or whatever it is. So it was this reframe about business, you having a business and it being a vehicle for other people to work within. And because I'd always kind of looked at from a very entrepreneurial standpoint. Why would anyone want to go work for somebody else when you could do it yourself and keep all the money, right? Always kind of the thought and have control of everything, and that's a very entrepreneurial thing. And there's lots of people that don't want to do those logistics, and just like you have people that want to rent a house and don't want to own something, right? Um, so the the seeds kind of got planted. One of my really good friends from grad school,
Hmm.
we ended up doing lunch like August or September. She's like, I'm burned out working for this group practice. I'm going to go take a sabbatical and come back. And she's like, if you do decide to do the group practicing and be interested in joining your practice, I'm like, huh, that's interesting. So she and I started spring of 2022, and it was kind of, if you're doing one or two other people, the way group practice really is set up and structured, it's kind of like solo practice plus one or two other people. So you're all going to basically be functioning relatively independent. You as the business owner maybe handle some of the admin and other structural things, but the administrative burden at that level is relatively small, especially if you structure it in a way to where, like my friend that I hired, very independent, um, and very much still is to this day. And gosh, we've known each other for going on 9 years, and yeah, it'll be 9 years in August. It's pretty cool. So, and we worked together for 3.5 in this capacity. So structurally, there's things that you do then to kind of get into stuff that needs to get reinvented to then go to the next phase of things. So the next phase of things is like, hey, so I'm going to shift over to like real estate. So you move from that one or two bedroom. Let's say we have a 2 bedroom apartment. You bring a roommate in, your cost of the rent goes down, and the next thing is you want to scale. So then you get like a 5 bedroom house. Well, what it takes to take care of a 5 bedroom house is very different than what it is for like a 2 or 3 bedroom apartment. And the costs are different. What you have to pay attention to, the maintenance and the things you need to do, all of those are functionally different. And so I know this seems like it's maybe not exactly a direct answer to your question. The different There's people I know that started group practice knowing that they wanted to be a group practice of 10 people, and I was just going to kind of experiment to see what happened. It decided I kept wanting to do it, and I'm still doing it now. So if I had to go back and do things again, some of the things I would probably do differently would be, um, have an answer to the question of, do I want a group practice or not? And if so, plan to scale up to say 6 people faster than I have. Just because if you move into that, if you're kind of in that in-between space where I've kind of been at just for a lot of different reasons, this past year is really just a lot of it's been, we went through a hurricane, it's been complicated. And my hurricane hire, as I call my second most recent hire, started, her last day of the VA was supposed to be the day that it was the ground zero day for hurricane coming through. And so she started with me that Monday. So there's been some just external forces that kind of have stunted my goals to get to where I want to go. But it's hard to be a business owner if you're trying to manage a 5-bedroom house without the infrastructure to do it. And some of that is timing and wanting to get into things faster so that you're not as spread out and spread so thin over a long period of time, trying to be the business owner managing infrastructure needs to then operate effectively a 5-bedroom house, I think is probably the best thing. So having maybe a different timeline or different time set of goals about that would probably be the one thing I would do differently.
Okay. I appreciate that.
I will say also the flip side of that is talking to my group owner friends that scaled really fast, or because I'm much more the systems infrastructure oriented person, I have systems in place that they're looking to revamp with 10 to 20 to 30 clinicians in some cases, switching EHRs because it's not cost effective. If you're in civil practice, it's obscenely expensive. We did that when it was just the 2 of us. So I'm positioned in those senses for scaling out really large. It's just the consequences, I haven't scaled that large. So there's been some other things that maybe I don't have the resources to do because I focused my attention on the ground zero infrastructure rather than maybe the referral streams being as fast as I would like them to be or some other stuff. Yeah.
Gotcha.
There's no right or wrong answer. Both get you where you want to go. That's the last thing to say on that.
Okay. Appreciate it.
Yeah. So welcome everybody else. This is the Q&A session, so anything goes. So it's
I'd like to jump in if you don't mind.
Yeah, please do.
I missed the first part of that, so pardon redundancy here, possibly. I'm not going to be actually opening up any doors until about 9 months to a year from now. Mm-hmm. I'm in the practice of the practice here a little sooner than most of you all have started out. So getting an early start, I guess. But the question I have is, to what extent would it be more appropriate to start off with renting that 5 office suite as compared to a 2 office suite or a 3 office suite? And I know there's not one single right answer for this, but assuming a slow referral stream at first, is it really, does it make sense to have a 5 office suite versus a 2 office suite or a 3 office suite? Would it make more sense to start off with just a smaller suite and then just, add a second location after that? What are your thoughts on that?
So what I've done, and this year there's a pivot taking place. So because most of my group started kind of still in the pandemic area and doing brick and mortar in person really wasn't a thing. I still have my Monday sublet I've had for 6 years since I first opened solo practice. That's always been a sublet. I just get a feeling like no one's ever going to leave that building. So if I want to stay there, I'm really only going to probably just be limited to Mondays. I'm probably going to keep it and not tell my clinicians I kept it and move them to my new bigger suite and just have my little go have a sane space somewhere in a quiet office that nobody knows I'm hiding out there. But I started with a sublet and then got a full-time office space in 2022, I think, just to have a place to not work full-time from home. So basically booked it knowing I was going to work remotely, but I was in town. And that was enough for us up until last summer with the way our schedules and our balance of in-person versus telehealth, I think we had two and a part-time person sharing that same space, and everybody got covered. So then added another room in a different location in town full-time. We're going to be giving that up because the building I'm now in, as a result of the hurricane and shuffling around, I now have 3 rooms in it because of just opportunities and how they've opened up in the past 6 months. So as they've opened up, I've taken over the additional rooms in that section of the building. And so I'm now moving into having a suite. The advantage of having those add as you need kind of things is I had locations in I still have locations in 3 different parts of town. So there are people in Asheville that don't want to drive over to West Asheville. So that's where the sublet is. My new space with the 3 suites is pretty central. So coming from downtown is convenient. Coming from West Asheville is convenient. Coming from everywhere but South Asheville is really convenient to that location. And so by doing the add a room as you need it, you can geographically locate yourself in areas that may open up some market share for in-person people. The advantage of doing a suite is you can then look at doing like a multi-year lease, and I'm working on that to negotiate as I kind of collect all the different like monopoly properties, like all the different rooms in this suite I'm in now. The hope is that about this time next year I'll have a 3-year lease for the entire section of the building I'm in, which would be 4 rooms with the option to maybe build 1 or 2 other smaller offices out in it on a 3-year lease. That's the goal. My friends that have practices, a lot of them, especially if they have a plan to scale, so if they're adding like a clinician every 2-3 months, you outgrow your rooms really fast. And so if you're planning to grow and add 6 roommates, let's say, looking at like a 3 or 4 or 5 office suite now does make sense if you can secure it, especially if you want to secure it on a multi-year thing and you can sublet. And that lets you kind of do the opposite of what I've done. So you get the 3 to 4 or 5 office suite, you get subletters as roommates, put them on a lease that allows you to kind of like renew every 6 months or a year. And then as you grow, you have to let them know ahead of time, like, hey, as I grow, I'm eventually going to have to move you. And, as my practice grows, and have that discussion there. So I think it's really up to you about how big do you plan to get? Are there real estate opportunities that make sense for getting a larger office space and then having basically subletters that don't work in your practice but are kind of shared office mates in that sense.
Yeah,
It's really
that's helpful, Andrew. And it sounds like having multiple locations just jumped in my mind that it might be advantageous simply because you have billboards, basically billboards in multiple locations rather than a single office location, like a big office suite. But that's not to say it won't make sense to have a larger office suite. That's fine. But multiple locations might equate somehow to multiple billboards, in some perspective there.
Yeah. Are you an insurance-based practice?
I plan to be an insurance-based practice. Yeah.
Okay. So I'm just asking because when it comes to filing claims, you are going to have to put the physical location that the service was rendered in. And so having multiple locations, whatever your EHR system is, and as you add clinicians to work in your practice, you're going to want to make sure that the correct location for the place of service is noted on the claim form. That's really just kind of, I guess, the big thing there is to just know that that's a part of things.
You can't just call one of those locations your headquarters and just use the same location.
No. So when you're filing that claim, it's going to have a location of where was the service rendered, just like who did the service under the rendering NPI. And so it's purely an administrative kind of thing. It's not necessarily you just want to make sure that's accurate.
Yeah. Okay.
Yeah. Just the last note on the multiple location thing, I haven't really noticed any significant cost increase. So there's a little bit of, it's maybe like $10 a month per location to add the general liability and other things like that onto my liability insurance. There's no meaningful difference. The other thing is if you do the satellite location stuff, you can often snag a room for less than what it would cost to get a suite that has 3 rooms. So not all of the like multi-room suites are going to be priced out at the same level that you might be able to find a single room somewhere. So, Jacqueline, I think you had your hand up.
Yeah. Hi. I'm curious what your thoughts are on having a 100% virtual practice, like how successful that can be these days. Because my struggle is referrals, and I don't know if it's just over time. I just feel like I keep hearing about these group practices that like referrals are just flowing on in, and I'm like, is it because I'm just virtual, or is it because of this or that?
The referral thing's really challenging. So my friend that was my first hire, there's something intangible I can't identify about why her Psych Today profile has the juju that it does. And the best I can figure is it's just the fact that it's her. because it's the same. It's not even exactly the really precise formulas you can go through. There's a really great how to write a profile thing called Your Badass Therapy Practice or something like that. The woman's in South Carolina. She's got a free How to Write a Psych Today profile thing that the last time I checked is still up, even though she's kind of not doing the coaching consulting stuff. But it's really great.
You're a badass therapist. Is that what you said?
It's Your Badass Therapy. I'll find a link in a second and drop it. Let's see. Your Badass Therapy Practice. And oh, interesting. So I was just going to drop the link in there. I'll still drop it in, but maybe she did finally shut down the website. She had mentioned something about planning to kind of close all that out. So you all can, I guess, see if it's still there. She had a really great tutorial on how to think through writing a Psych Today profile that was going to be effective. But in terms of the referral streams, and this is something that it's complicated. So different markets have different needs, different therapists have different receptions in different markets. Having a niche is really helpful depending on what that niche is. Can be, if like an example, so there's about 5 couples therapists in Asheville out of the thousands of us that there are that do EFT, that have the full EFT certification. And so, or training, or however they build that out. And so they're generally always booked. Probably half the therapists in Asheville offer EMDR. So even though EMDR is a specialization, EMDR is just kind of almost half the people here do it, it seems like. So if you're trained in art, however, the accelerated resolution therapy, that's more niche and more understood now, and people know to look for that. And they are functionally different, and there's reasons why one is preferable over the other in a clinical sense. So having something like that you can kind of tag on and market, and then talk to people that maybe have clientele that are appropriate for that kind of referral can be really helpful. This past Friday was our monthly group owner group get together, and we were talking referrals because there's what has worked. This is the summer. This is when everybody kind of reevaluates what changed for 2025 versus what worked in 2024. And we do this every year. And about mid-year, you kind of say, this is still hitting the way it did. This is not hitting the same way it did. And what's different? And then what are the trends in the market that we think are going to happen? And one of the trends we identified was it's something like a vertical something. So the idea is you have a doctor's office, like a primary care, and they have an embedded therapist in the practice. And so the doctor's initially going to refer to that embedded therapist that's in the primary care practice. And that's becoming a more common thing. It started in our area with the direct primary care. So the non-insurance, you pay a membership monthly and see people there. And it's getting to be much more widespread, especially when you have insurance companies buying practices up and installing everything in a one-stop shop kind of thing. So those therapists are going to get overwhelmed, because if you have your average doctor in a primary care is going to have about 500 clients for the year on their caseload, and they only see them a couple times a year, but that's a huge number of people, and that therapist in a doctor's office like that's going to have an embedded therapist is going to be overloaded like a school therapist might. And so trying to find relationships with those types of therapists is good. Consistently, it does seem like therapist to therapist is still the best referral network to have. So as you meet other people, and it takes some time to do so, and I realize it's not an immediate thing, that still ends up being really the best way to ensure consistent referrals among other people. And yesterday in the next level practice thing, it mentioned you can go on Psych Today and start doing virtual coffees with people, like, hey, I'm a therapist looking to meet other therapists across the state. Do you have 20, 30 minutes? You want to meet up over Zoom and just chat and get to know one another? And you can start with therapists that on their profiles list that they're full, because they're probably still getting phone calls about, hey, I really want to work with you. Your profile really spoke to me. And they maybe have a 12-week waiting list, and they're going to have people that want to come in sooner. And so finding people that are already full end up being really great places to start, even if they're in the same niche you are. Because especially if you're in the same niche, actually, because then you're more likely to get referrals that they can't because of overflow. Mm-hmm. So I know there was a lot in there, but just different things change every year. Psych Today, I think, was a lot better. And then getting back to just being a virtual only practice, I've had clients in my practice that are therapists that have been virtual only and don't even live in the states they practice in, and been doing that for a decade or more, well before the pandemic. Part of what we're noticing here is probably for 2 years, there's been an increasing desire to be less on screen. And so more and more people are like, telehealth is okay, but really the in-person thing. I actually just recently switched therapists myself for me and really wanted somebody in person. So switched off of doing telehealth, even though it's more convenient. But just to have that, there's something you can't really replicate on telehealth, of that container to where the room's holding space for both people to be in it and work through what they're doing. You are still going to get a ton of people that do want telehealth. And the upside of the telehealth only model is you get the entire state or the multiple states you're licensed in as a market. So if you're in a tiny rural area, making friends with people that are in much more population center type places will yield higher referrals for a telehealth only practice.
Okay. But do you feel like it almost creates a problem that there's so many options and you're not just like the therapist in Durham?
Yeah.
You know what I mean?
Oh, so are you another North Carolina person?
Yeah, I am North Carolina.
I'm out of Nashville. So it is, I don't know what there is a phenomenon that kind of has, like, I think Netflix is the name. It's like the Netflix, like, there's too many options, so you can't pick anything to watch. So
Right.
you're like, hey, I want to watch a movie. I don't know if I want to watch Star Wars or what. And you just start scrolling through Netflix, and after 20 minutes, you give up because you've been overwhelmed by too many choices. And there's a decision-making fatigue that does happen with that. So trying to have some way to set yourself apart. And again, if you can kind of link up and being known as somebody that has openings to a select group of providers, then that can be really helpful, because people know, okay, Jacqueline's got openings. I don't at the moment. Jacqueline works with this population. Great. I have somebody that's looking for that, or maybe I need to refer this person out that I've worked with for a while because our needs changed. And then they can kind of like send people your way because they know you have openings until you get full.
Yeah. Cool. Thank you.
Yeah, the Raleigh-Durham, one of the consequences of the pandemic, and especially because like today allows you to add 3 different geographic locations, I'm pretty sure I'm listed in Raleigh or Durham as well, even though I don't live there. And just to accommodate the telehealth side of things. And it's not really been the most helpful. And even in our area post-hurricane, there were a lot of people in different areas across the state that really stepped up to like help us navigate all the hurricane stuff. And now what we're finding is some of those people haven't politely bowed out to go back to their geographic area and are still kind of like sponging out of our geographic area in a way that's maybe not the most helpful to the therapists that are here. So,
Okay. Thank you.
yeah. Lastly, SEO is going to be a big thing. So run some SEO checks to see how well your site's doing in terms of ranking and things like that, because it does make an enormous difference, especially if you're virtual only.
Andrew, how do you like Gusto? You just switched over.
I don't know. I'm going to run my first payroll this week, so I'll tell you afterwards. So far, it seems really easy. Everybody got set up. I think my admin needs to set up her 1099 stuff. But going in so far, I think I paid a little extra for the HR support side of stuff. But everybody's got their job titles. You can kind of set different job titles. You can set departments. You can configure those things. I'm planning to run payroll, I guess, probably tomorrow afternoon, to see how that goes. I emailed my entire team to say, get your timesheets in by 5 today. So that'll give me what I need to actually go through and calculate everything, and then we get to see how it works. But the initial thing seems really easy to set up, and it took less time, it feels like, on my end than it did to set up QuickBooks Online.
Are you doing any integrations with it?
Not yet. It's going to eventually integrate with, I'm switching over to Xero XERO for accounting software because I really, really, really despise QuickBooks Online. It's really garbage software. Case in point, ask a question on how to do something in QuickBooks Online, go to their support walkthrough, which will usually be up to date as in the past 2 weeks, and then try to do it. And then you'll see what I'm talking about, because the instructions never seem to match how the system actually works.
Is Xero an affiliate or a partner with Gusto? That one of their that they kind of advertise?
It will integrate. I don't know if they have that kind of affiliate relationship. find systems that talk with one another, because the administrative burden, especially if you're going to scale into a group about trying to get stuff from one system and do the in-between and then get it back in the other system, that does not scale. Yeah. Joanna.
I have a question. So I'm planning to hire therapists soon, right? So if I want to start hiring people for 4 hours, is it better to go a W-2 route or the 1099?
It depends. So some of the depends on your state.
Mm-hmm.
So certain states like California, I'm pretty sure Colorado, and probably some of the other, Rockies to the west states really don't allow at all for any kind of 1099 relationship. So some of it's going to be state dependent. You can have a mix of 1099s and W-2s performing relatively the same job roles. It would be best to label them differently. So I do have one 1099 person still. She originally she was working 6 to 8 hours. Now she's down to about probably like 3 to 5 a week average kind of thing. So keeping her 1099 makes sense because I have almost no overhead. I pay for HR and egress basically, and that's it. And that's just so she has something that kind of comes out from the business, and she doesn't have to then figure that on her own. So that's probably a little bit of a stretch in terms of the 1099 relationship, but I don't think it's enough to really get me in trouble. And the bigger litmus test being how much are you financially dependent on this company to work for? So if you're talking, I would say probably if you're talking 6 or less, I would go the 1099 route.
Mm-hmm.
Just know that if you're going to convert to W-2 later on, you need to set it up in a way that when you convert them, if they do decide they want to come over to you full time, or start seeing maybe 10 or more people a week, then switching to W-2 is going to make sense. So however you choose to pay structure that, make sure it's something that you can replicate under a W-2 model when you account for taxes and malpractice and workers' comp and other things.
Mm-hmm. And I have a couple of more questions to add to that. So do you know how much Gusto takes for a W-2 position on taxes, like hourly?
So the way the tax,
Gusto, but in general, how much do we need to pay in taxes?
Okay, so there's two parts to that. There's what Gusto charges to pay people, and then there's what Gusto is going to withhold on people's behalf as a W-2. Withholdings as a W-2, so we as business owners with employees withhold the employee side of tax, which I think is 7.6%, and that covers, I think, the income tax, the Medicare, Medicaid, Social Security, that whole lump of things. So it's about 15% and change if you're working independently as a contractor or self-employed. So that amount of money that's withheld comes out of the earnings. So let's say that if you're paying your clinician a $50 clinical rate, let's say, per hour, and they do 10 hours, and so that's $500, and let's say the amount of withholding that we're supposed to withhold as a business owner is 7.6%, and the income tax piece of that's going to vary depending on how many deductions they have. So if you have no deductions, the withholding is going to be higher. If you have like 17 kids, the deduction is going to be almost none because of all the dependents and things you have on your taxes. And so the amount that really gets held on the income tax side of things is going to vary out of that based on what the deductions that the employee specifies. But the withholding amounts coming out of that $50 an hour, or that $500 amount. And that's not the same as the other parts of things that we do pay, which is workers' comp and unemployment insurance. And those are going to be separate from that $50 an hour. So if it's $100 a session and the business pays the person 50 of those $100, the unemployment insurance and the workers' comp is going to come out of the $50 out of that the business kept. Am I kind of making sense?
Yeah. Mm-hmm.
So I think I'm getting my math right. It's one of those things that the amount of money that's withheld is a fixed percentage. The actual dollar amount is going to vary based on the amount of work performed, and thus the wages paid.
Mm-hmm. Okay. And yeah, thank you for that. So it gives me an idea, that, okay, that's the withholding. So the person is going to end up getting like $40 per hour or 35, something like that. Okay. And then the other question. So W-2 means, as I understand, that regardless if the employee works or, has session or doesn't have sessions, let's say 4 hours, right? I'm responsible still to pay, for paying them those hours. Is that correct or not?
So the way it's been worded to me, and I'm in North Carolina, and North Carolina is a right to work state, and so everything favors the employer. So if I just woke up one day and decided to fire somebody, there's no protections to the employee for that. I could have no reason at all, and that's just to set things out. And North Carolina is also a state that's never does not have a separate state minimum wage from federal, and so minimum wage here is still $7.25 an hour. And it also doesn't have any of the overtime laws like states like California do, to where if you work beyond a certain number of hours in a day or a certain number of days a week, you get paid more because you've done more work or had a work schedule that wasn't consolidated effectively. So the way it's been explained to me from employment attorneys here is I only need to show that the employee was paid the minimum wage for the amount of hours that they clocked and actually worked. If you have a situation to where it probably would depend on how you were having the employee track time. So if you're going to say, hey, you're going to see client, you work a shift from 8 to 12. And if nobody shows up in that shift, then you would probably have to pay them for those times for all the appointments that weren't kept. If you do what most practices do, which is allow clinicians to kind of set their schedule and it's an appointment-based thing, well, if the work is to be a therapist and the person to receive therapy doesn't show up, well, the clinician technically didn't work. So you're not necessarily obligated to pay them for the time that they didn't work, even though they had the potential to.
Okay. Got it. That works. Thank you.
I just want to acknowledge, like, it sounds awful talking about these kind of relations as a person and from an employer lens, because the HR world of things is looking at saving the business's bottom line, and from the business lens, which doesn't always like feel good in terms of how it means to be the employee receiving that, right? So I just want to name that that's generally how our whole economy and economic structure is set up.
Yeah.
And it doesn't feel good.
Yeah, exactly. But thank you for mentioning that. Thank you.
This is also where things like having a cancellation policy come into play. So, like an example is, we have a late cancellation policy. Originally, when it was 1099, it was less because the agreement under my contractors was you can decide if you're going to charge the client or not. The business isn't going to take anything, but I also don't have to pay you anything for it. So you could miss a session, charge $50, and then the clinician would get to keep all of that because that would have been less than any of the commission that they would have received for seeing the client in the first place. And since the business didn't have I wasn't obligated to necessarily pay them an hourly for that kind of thing, and didn't have the same overhead costs. Under W-2, what I've done is everybody's got $100 like cancellation missed appointment fee. And so the business still takes the business percentage from that, and then the clinician gets their percentage out of it.
So how do you, if you don't mind sharing, what's your split? What is a market, the market rate going for a split right now?
So for my practice, it's pretty similar to most of my colleagues. And I know this because we have pretty active discussions once, maybe twice a year about what can we afford to do?
Yeah.
And that's always the conversation. What can we afford to do? Not how much can we keep? And the general consensus is right around a 52% split is affordable.
52% to the practice and 48% to the therapist.
Yeah.
Okay. Thank
And
you.
again, if you figure in the employer side of things versus a 1099, so if what that works out to is about a 63-64% split in a 1099 sense because of what the employer is going to then pay tax wise. And there is a employer side of tax. So basically you can kind of figure I match what the employees paying out for their deductions and stuff. So there is about a 7.5% thing the business does incur. So I guess I guess they get their $52 and there's still another 7.5% roughly that I'm going to pay per wage hour, I guess, on their hourly and stuff, as well as the workers' comp and unemployment. So it seems like there's about an 11% additional cost as the employer above that percentage split to the person.
Got it. Thank you.
I do have friends that pay flat rate, and the way they calculate their flat rate is look at distribution of insurance payers and appointments, and then they kind of have to see if they can come up with a relatively conservative adjustment. So let's say you have 3 payers. So for us, Aetna pays the highest, then Blue Cross, then United. And United pays notably less than Aetna and Blue Cross, not as notably less in like half the amount that Cigna tends to offer, which is why we don't take Cigna. But for some of my clinicians who are provisionally licensed, they are not able to be on the United panel. So for them, their hourly averages from insurance reimbursements are always going to be higher because they can't be paneled on the lowest payer panel. And for everybody else, I would kind of have to look at roughly how many United, what percentage of clients do we have are United? So if say 10% of them are United and then the other, 40%, 40%, and let's say 10% private pay are on those higher payers, that flat rate could be higher based on the number of United clients being so low. However, if it was the kind of thing that, let's say 2/3 of our clients were on our lowest paying insurance panel, that flat rate, which should be adjusted down to accommodate that flat rate side of things. Pay and payroll gets really complicated, and then at some point you're going to end up with probably 15 or more people if you decide to grow that big, and then salaries are going to become a very realistic option. Steve.
So when you were a solo and you went to group, did you panel with your NPI 1 or did you for the insurance companies, and then as you got people, just added them under an NPI 2, or did you have to go with? I think I'm confusing myself now, but I guess the question is, it seems like maybe you're panel with an NPI 1, but going into group, you had an NPI 2. Were you able to panel with a few clinics, or did you have in New York, in New Jersey, they're telling me, well, we can't put you under an NPI 2 unless you have 3 or more people, which is just ridiculous. I don't have 3 or more, but
I'm just sitting here thinking I should do like a little mini series on insurance and questions. So I don't know where the advice came from back when I was incorporating and starting to get set up with insurance back in 2019, going into 2020. Everybody was like, so the state here mandates, my board mandates us having a professional LLC, and not everybody does, and the state doesn't enforce anything. But it is one of the things that we're technically required to do, even though it's not really enforced. And so when you have a PLLC or an S corp, you can then get an NPI 2 because it's based on an agency, and there's a different taxonomy code that goes with it. You can look this up on the NPI registry and these other things and these big rabbit holes. And so on the insurance claim form, down in the bottom right-hand corner is the billing NPI information.
Yep.
And people just said you should get contracts to your business, not contracts to you, in case you ever decide down the road to do this. And again, this was before I was in next level practice and people had set this up. And so I did. And so a couple of years later, when I was looking to add my first contractor, hire person, it was real easy because we could add them directly to my Blue Cross contract. There were 2 or 3 other panels, which are now defunct because they were trying to overpromise what they overpromised what they could afford to pay. So they went out of business. It's a bummer because when they were paying really well and they're out of business. But those were also group contracts. For panels in North Carolina, like Aetna and United, one of those, people keep telling me that they will never do a group contract at all. So it doesn't matter if you have 25 people or not, everybody's basically in an individual contract. And so how that sets up in a group is the contract basically is to the directly to the provider, but the tax ID, which is the businesses, and then the NPI2, which is also the businesses, all get put on there so that the pay comes through the business, even though the contract is technically directly to the client, because the way the insurance contracts work is it's based on tax ID. So under that scenario, it still doesn't prevent that clinician from getting their own individual contract under a separate tax ID. And that's also how people can be work in multiple places and take insurance at multiple places. So does that kind of roundabout answer your question? To anybody listening that hasn't done contracting yet, get an NPI, set up a business entity, get your NPI2 and do your contracting under NPI2 to start with, regardless if it's a group contract. Really the only difference between a group contract is everybody's named on one contract versus individual contracts with the group's tax information on it.
I guess the roadblock I ran into is, so I had an NPI1 and I had like 2 insurance panels there. But then when I tried to do the NPI2, they just kept saying, well, you can't, we can't, credential you unless you have 3 people with you already, which is very weird. I mean, I just think that's unrealistic. There's no way I'm going to hire 3 people right now and just to get on an insurance contract. Have you ran into that?
Yeah. So what we did for Aetna and United was, as we added providers, we would add them in. They would have an individual contract, but the billing NPI and tax ID number was the businesses. So it's technically an individual contract with them, but it still has the NPI2 information going to the business.
So you were able to just get the NPI2 for yourself as an individual, just by yourself, before you started adding people. They just allowed you to have it? Mm-hmm. Yeah, you see, they were not letting me do that.
So I think there's maybe 2 things going on. You have to have a business entity with a tax ID number, mm-hmm. and then you can go to the MPPES site, if I'm remembering the thing right, to set up, and you register your MPI1 and then you register your MPI2. Mm-hmm. And that MPI2 registration is going to come with a business MPI2 taxonomy code that says, I think it's ambulatory outpatient adult. It's like ambulatory mental health outpatient adult something. Anyway, that's what our taxonomy is. What I did is I found another counselor in the state and that I knew how to PLC, and they just copied what they did, and it seems to have worked fine since then. But if you don't have the MPI2 registered and you don't have a tax ID registered, you then can't get a contract with those on there. Yeah. The issue with the insurance company is probably communicating to them to say, hey, how do I have an individual contract, but have that go under my NPI2 because we have a business entity that we use to render services for tax purposes and other things. How can I add a clinician and set up a contract that uses my NPI2 and my tax ID number to cover those things?
Yeah. Hey, I get a different biller. Maybe they don't know how to do that.
Well, there's also people that do billing aren't necessarily the same people you want to have do credentialing.
Okay. They do both.
Some do both.
Yeah.
I'm transitioning off my biller. So my biller had an in-house credentialer as well, and they only did credentialing for their billing clients. And so choosing to switch billers, just from like a logistical and cost standpoint, that also meant that I had to find a new credentialing person. And so I have a new credentialing person. She's taking over kind of managing like all those attestations about, hey, is your information up to date, managing CAQH profiles and all of that stuff. So that's what the credentialing person's handling. And then I have a separate biller who's going to come in and troubleshoot stuff that's stuck, but they're going to come in and do that through my EHR, which we're now billing out of instead of using their outside system.
Gotcha. Okay, thanks.
Yeah. Since they are going to charge hourly, you're not really out any more money by having 2 separate people. And if anything, you get people that are a little more attentive to some of these nuanced details because it's their area of focus.
Mine was charging, they charge 5% for all the claims submitted, and then they just do $100 for each panel, So They do both, but I think I probably have to do that. Just get somebody different. They probably just don't know what they're doing.
I mean, that's a pretty decent deal, actually. Like
I
that's
thought so. But then
yeah.
somebody started coming back to me and say, "Oh yeah, well you're not allowed to do this," or they're saying, "No, you need to have at least 3 people." That's so. But what you said makes sense. Maybe they're not asking the right questions, or maybe they're just not.
Yeah, I'd have to look, but I'm sure if I found my Aetna contract, it probably has it listed. I know it has the business entity listed because what that allows me to do as a group owner, especially since I'm in the middle of like auditing a bunch of stuff right now that's claims, I can, because it's linked under my tax ID number or my NPI2 number, regardless of who did the work, I'm then able to, in systems like Availity or Blue E, which is the Blue Cross portal, or United, I can go in and look and see what happened because all of those are connected to my business, even though that they're individually contracted.
That would be a complete game changer. Because I didn't want all these insurance panels associated with my NPI1 because I don't even necessarily want to, I just want them for the clinicians, and maybe here and there because I already have a large enough of a caseload. So that would be a game changer right there.
The other really big thing and reasons why you want NPI2 and this stuff set up is there's what's called supervisory billing, and there's also what's called incident to billing, and they're not exactly the same. So they kind of appear the same, but they're not technically the same. So so I'll use Aetna as an example. So Blue Cross had the state employees health plan contract for administration up until the end of last year. And so Blue Cross was always paneling with associate level people, which is what we call our people under supervision in North Carolina. In Florida, they are considered postmasters interns because they technically have no operational license at all. And reasons why I'm bringing this up is to distinguish between incident to versus supervisory. So last year under Aetna on the initial rollout, it was still considered supervisory billing, which meant that for only LCSW associates, not counselor associates, counselor associates basically the credentialer would email the request to add a person to my group contract or add a contract. And because I was affiliated with my NPI2, they basically did a good faith thing that said, hey, we're adding Steve to Andrew's practice. Andrew's in good standing with us. We trust Andrew to hire people that are also going to be in good standing with us too. And while the paperwork's getting sorted out on our end, Steve can go ahead and bill under Andrew's group practice. And for the time being, while we get our paperwork together, we're going to use Andrew's rendering NPI. So my NPI1 is the rendering provider, even though Steve did the work, and do it. The difference between incident to billing, which is what that is, versus supervisory billing has to do with, do I also then have to sign the note? So in Florida, the way insurance billing works for LCMHCs, from my understanding, is they are postmasters interns that are not able to bill insurance because they don't have an NPI number yet. And so therefore it's supervisory billing because the clinical supervisor for that person is the rendering person that does the service, which also means that they have to then sign off on all the clinical notes as well. As of this year, I no longer have to sign off on Aetna notes for LCSWs because the state employees plan forced Aetna to contract directly with clinicians that are associate level. That's going to change because Aetna finally formally announced to the public, I think in the past week, that they're discontinuing all ACA plans as of January 1, 2026. So I'm sorry you have such a good deal with your biller. And it does sound like having somebody that can kind of like go through these like really nuanced kind of things is really going to be what you need. And it could be the kind of thing you break up with your biller. And so I was paying roughly $150 a panel to have people added to different insurance panels. So, $100 is a really good deal. It probably would go up to about 150 if you use somebody else.
Yeah, and I don't mind as long as it's just done correctly. And they're good people, but that's just so weird. Because the whole way that thing is set up just didn't make any sense at all. So I have to look into that.
But that means the insurance company is working the way it's intended, which is to make it as hard to get paid as possible.
Yeah.
That's the goal. Erica.
Hello, everybody. I think I'm so behind everyone, but so I'm trying to understand because I'm always getting stuck with I'm stuck at the phase of trying to hire, especially like you said, supervisory or provisional. So it sounds like that you're saying if they get their own NPI and then do an individual, and then you can bill under your NPI too in your business.
Yes. So to do any insurance billing at all, you have to have an NPI number. And then in North Carolina, I think there's a separate Medicaid number if you do elect to take Medicaid. I don't know that there's a separate one for Medicare. So anyone that's billing insurance has to have the NPI number. And the advantage of having the group contract or having things under the NPI too is that it speeds up the time from when you tell the insurance company you want to add somebody to your group and have them take this insurance to how soon they can then be reimbursed for those services, even if it's billed under a different NPI number. So there's the NPI2, which is the billing NPI number, and then there's the NPI1, which is the rendering NPI number. And so the having the NPI2 infrastructure in place allows that rendering one to be a little flexible. And at least the way I was told is that it did, because I was the employer of an LCSW, even though it was technically supposed to be a clinical supervisor, that was acceptable per Aetna for doing supervisory billing under the time frame that I did. But basically, as a business owner, I can send it to Blue Cross to say, hey, I'm adding, Nate or Jessica or Joanna or whoever, and then about 72 hours later, I can submit claims and they will be covered, even though I think initially it is with Blue Cross, it was a little different. I think Blue Cross still sends their NPI one as their rendering one. And I think for Aetna, for a while, they were using mine. And then once they were fully on the once they had the contract done, then they came off. And it works for people under supervision, and it works for fully licensed clinicians as well.
Okay. So I guess my next question is, so you say you're paying like $150 to get them credentialed. Is that something you're working out in your contract when you hire them? Because you're doing this to get them individually credentialed, and then I guess I'm thinking like if they don't work with you, like you put this money out, like how does that work?
So I had a discussion with an appointed attorney about a month ago about these kind of things. That was one of the specific questions I asked about, is there a way to put in onboarding costs? And she said, yes. And her recommendation was to have it be for specific things. So one of her examples was like, if you had, say somebody came in and they're going to have a very specific, expensive continuing ed thing, like or like certification. Let's say you want to have everybody in your practice get EMDR certified. And so, EMDR is a couple $1,000s to have them done, and credentialing is, much smaller, but it is a fixed thing that you can do. And so what she said was easier in legal, at least in terms of North Carolina law, is rather than say, hey, if you leave before 12 months, you owe the practice $1,000 for onboarding in just a general sense. She was suggesting that it would be easier and to enforce in a legal way to kind of withhold. Basically, you would say, hey, I will cover credentialing for free if you stay in my business for a year, and say that it costs I'm going to withhold $150 per insurance panel until you've been here for a year, meeting the requirements that we've outlined in our employee handbook for compensation and other things. So they basically have that $150 withheld on the front end as your investment. And then once they've been around for a year, what's the, vested. So once they have vested for a year, I'm thinking of like the financial sector term for like if you're getting stock from like a company, like you have to be around for 12 months. Similar idea there, to where that $150 is identified as being withheld and and you will hold it. And then if you stick around for a year and invest in your company, then they finally get that on their next paycheck.
Oh, that was a great suggestion. Thank you.
Mm-hmm. This way you don't have to run into the, hey, well, you left early and now you owe me $1,000. What are you going to pay it? And they probably left in a way that they don't want to talk to you anymore. Even if it's on their own accord, because people do come in, they live a caseload and then bail on their own. you know. Any other burning questions? Jessica, are you have any other ideas at this point?
Any other ideas, like
Or just
specific to the insurance questions,
or just since you've been listening in, any questions?
I have decided to try to go private pay, and this is very complicated, and this is why, because it's very confusing. So for now, that's what I'm doing.
If I had to rewind to starting out, I would have started out private pay and stuck with it.
That's
It
good
would
to
have,
hear.
you know, just because I mean, just there's so many things about insurance that are awful. Like right now in North Carolina, a lot of the Affordable Health Care Act, like marketplace plans, which have a prefix of YPI, there was some glitch on Blue Cross's thing. So for 3 weeks, none of us could file claims. You couldn't even look up member coverage. And so knowing there's about a 3 week lag between when you file it and then the checks actually process and then the stuff hits your bank account. Well, that's, you know, for the first week of June, it's going to be July before any of that money hits my bank account, right?
Yeah. But also, this is, you know, we're looking in economically tough times, and private pay, it's hard either way, I think. And it's hard deciding either way, but it just feels like so much paperwork and stuff. So it's a slow burn for me, but I think hopefully it'll be worth it.
The other kind of economic consideration, and this is something that's definitely been a hot topic along a lot of my colleagues, is given the current perspective around healthcare and who foots the bill for things and what should be covered in terms of who's pulling the levers of power, it's maybe more precarious to be an insurance-based practice at the moment because all the health insurance parity disappeared. So for reference, what that meant is if you look at your insurance card and it says, hey, to see your primary care, it's $10. If you see a specialist, it's $100. Mental health parity meant that it should match your primary care. And it was left up to the states to choose to opt into that, even though it was a federal pseudo mandate with no real force to it. And the administration basically said, we're not going to enforce any of that anymore, even though Biden on his way out had said, tried to put in some bigger enforcement for making sure that that was really a thing. So there's also when there was never a telehealth mandate put in. Mm-hmm. So the instant the emergency orders ended, Florida, all of the Blue Cross plans in Florida immediately dropped telehealth, like immediately. So it's private pay at least has the stability about, as a customer, I know what it's going to cost when I go up to the register to check out. And I always explain to people, I'm like, the way insurance tends to work is you walk around the grocery store, you grab your like dozen eggs, which now is like $17,000, and we need insurance and a copay to afford them anyway. But let's say it's $10. So you buy your $10 dozen of eggs, and then you get to the register, and the register is like, oh, actually it's $12. And you're like, but the sticker said, and they're like, yeah, but it's $12. And so you're like, fine, I got to go home. My kids are hungry, whatever. Like, got to take my dogs out. So you pay your $12 and you go home and eat your dozen eggs over however long it takes to eat a dozen eggs. And then, you know, a year later, the store calls and it's like, hey, remember that dozen eggs? And you're like, no, but what are you talking about? And they're like, oh, well, we sold you a dozen eggs for, you know, $12. We need 6 of those back. And you're like, but how do I do that? I ate them, right?
Yeah.
And they're like, well, like, I mean, you know, like, see Steve laugh, but like, that's the absurdity of our system though, right?
It is.
That really is it, right? Hey, well, we just, you know, well, why is it? It's like, well, we didn't feel like now in hindsight, we regret giving you those eggs, so we need them back. And if you don't, then we're going to come beat you, you know, and that's our system. It's absurd.
It is. But I think it's almost like hedging they're willing to take a gamble on that if insurance like people don't understand and they just see insurance is going to be cheaper. And so they don't even entertain private pay. And for me, I work with sleep and there's not many providers. So it's like, it's either they work with me or they don't get help. Mm-hmm. And so they say, well, my insurance doesn't cover it. So
There's also, and this is a broader discussion for another day for sure, and we're kind of wrapping up on this note, but there is something really unique about how people approach mental health providers to say, well, I have anxiety. Like if we had a broken leg and you go to the doctor, or you need an oil change and you go to the mechanic, no one seems to argue about the fact that there's a cost to that, right? So even if insurance is going to pay for the broken leg, people know they're going to have to pay something for the broken leg, but the insurance isn't going to cover all the money, right? And for whatever reason, with mental health stuff, people are just like, oh, well, I'm anxious, so I should get treatment and I don't necessarily have to pay for it, right?
Mm-hmm.
Trying to get people to call their insurance, like I have I've literally every question you need to ask, NPI numbers, all the service codes, everything. People get it. It's downloadable on my website. It's downloadable on the forum to request a free consultation. It's included in the email to say that you filled the form out. It's part of our intake packet work. They literally get it at least 4 times. I think they get it 5 times because I think it also goes with the Acuity link that we send out to then do the free consult with providers. Almost nobody ever calls. And then they get mad when it's like, well, it's going to be $50 a session.
Yeah.
Right. And you're like, but you've had the opportunity to call this. It's like, it's the same thing going back to the grocery store analogy. And this will be my like soapbox into this little Q&A, but it's like you never checked any prices at all for any of your groceries. And you get up to the like checkout and the cashier's ringing things up and you're like, well, I don't want to pay $7 for that. And you're like, but, and then you're mad at the
That's
cashier,
the rate.
right?
Yeah.
Right. You're angry at the cashier who didn't set the prices because you then have to pay for something you said you wanted to buy. And this is the experience so many people have. And at least with private pay, it's $100 a session. Take it or leave it, right?
Yeah.
So at least people on both sides have a clear understanding. You also don't have to wonder if unless you have a random issue with a credit card processor, and finding a backup is a lot easier to do than finding. There's no way to file a backup claim.
Right, exactly.
If Stripe's down, you could run it through Ivy Pay or something else today, versus have to get set up with a whole new like USPS or FedEx type system to then file an insurance claim.
Yeah. I mean, yeah, exactly. These are things I'm weighing all the time.
Yep. I honestly would rather take a 10% discount and deal with cash pay people than to have to deal with their insurance. It's that much. It's worth it to me that much.
That's what everybody keeps saying. So that's really good to know.
Yeah. So thanks everybody for coming. Lots of good questions. Talk to y'all soon and have a good rest of your week. All right.
Thanks.
Bye.
You too. Bye.